Good evening and welcome to this special Heart Foundation webinar offering a practical update on the role of the practice nurse in the heart health checks, also known as absolute risk CVD risk assessment. This webinar is being presented in partnership with the Australian Primary Healthcare Nurses Association, APNA. I'd like to acknowledge the traditional owners and custodians of country throughout Australia and their continuing connection to land, waters and community. We pay our respect to them and their culture and elders past, present and future. The aim of tonight's sessions are discussions around the practical implementation of the new Heart Health Check MBS item, the role of the practice nurse in supporting absolute CVD risk assessment, and system-level nurse-operated strategies to maximise the primary prevention of CVD. We're very pleased that you've joined us this evening, and if you have a question, please feel free to type it into the message box that appears on your screen. Although we're very keen to hear from you, we apologise in advance that we may not be able to cover all of the questions that are asked in this evening's webinar. If you do have any technical issues tonight, please feel free to call Redback Technical Support on 1800 733 416. Now let's get started, and may I introduce myself as the facilitator for tonight. My name's Margaret Dempsey. I work with APNA and currently working to build nurse capacity through the Nurse Clinic project. My previous roles have included primary care consultancy with a focus on supporting quality improvement initiatives. I'd like to welcome Associate Professor Ralph Audham, sitting beside me. Ralph is a GP based in North Carlton and Fitzroy, who has had over 30 years as a leading advocate for best practice in chronic disease management. Much of Ralph's work promoting primary health care has been in partnership with local hospital networks, PHNs, Diabetes Australia Victoria, Cancer Victoria and the National Heart Foundation. I'd also like to introduce Ms Lisa Taliana, who's a primary healthcare nurse. Lisa's an advanced practice registered nurse and has led teams and projects for over 20 years within the general practice setting. Lisa will bring her proficiency with data management and data utilisation to our discussions. And finally, I'd like to introduce Kathy Godwin, who is a registered nurse and practice manager. Kathy will bring to our discussions her expertise across those two general practice roles of practice manager and registered nurse. Her recent work engaging primary healthcare nurses in APNA's chronic disease and healthy ageing workshops will lend a strategic perspective. So thank you all for joining me tonight as we run through this session, and to let people know that there are more comprehensive biographies available on the National Heart Foundation website. So firstly, Ralph, I'm going to speak to you first. Talking about absolute CVD risk and where are we now, the first CVD risk guidelines were published a decade ago. So what's new in this space and why are we still talking about CVD risk assessment?
It doesn't seem that long ago actually, but I think part of the answer is the slide that's currently on show here, just showing the impact that heart disease has on people within Australia. And when we actually drill down to data, we know that there are people who are missing out on treatment that need treatment, and in fact there's also people who are being over-treated. And so really, if we go to the next slide, we can see the march of absolute cardiovascular risk, how it's actually progressed. And I can remember, the very beginning when we first launched the first book and we were trying to get the concept of absolute cardiovascular risk out there rather than managing individual risk factors. And that's something that, as a young doctor was drummed into me. You managed blood pressure, you managed cholesterol. But what was lacking was that comprehensive overview, because in fact you don't have to have really excessive levels of blood pressure and cholesterol to be at a high risk. And so then those guidelines have progressed and have become part of the way that we do our work. And let me say it's culminated in this fantastic sort of new heart health check, which can really maybe focus us a lot on implementing the absolute cardiovascular risk across a broad swag of our population. So if we go to the next slide, because when you're talking about the gaps, we have some data from Medicine Insight, And look, this was, you can see that they've extracted some data from a very large number of practices scattered around Australia from, all different, socioeconomic backgrounds. And if they basically took a random sample, 25% of people aged 18 years of over. So that gave them 750, 1,000 sort of patient encounters that they could then look at. And that was involving 441 general practice. So we're talking about a large sample here. Now, of those, when they drilled down to those who, would be eligible for a heart health check, it ended up being around about 350,000. Now, so that's nearly half of that particular group that they were looking at that were actually eligible. But when you drill down to the data even further, so this is now looking at how often an absolute cardio risk calculation is actually recorded within the medical software. And you can see it's tiny. It's 6.7%. Now, I know some people will be using the online version of the absolute cardiovascular risk. So this is purely, from the cardiovascular risk that's actually embedded within the software. But even so, that's a very tiny amount. And if we're not actually measuring and recording the absolute cardiovascular risk, well, how do we know who to treat and when to treat? Now, when we drill down a little bit further into the actual data, so if we go to the next slide, you can see that the actual elements of the cardiovascular risk, there's quite a few things that are still outstanding. So, if you look at the top one, 67%, we're talking about a blood pressure measurement within the preceding 2 years. So these are regular patients of the practice. So only 67% actually had a recorded blood pressure actually recorded within their software. So, we need to do obviously better in recording it. Oh, absolutely. And again, if you're not measuring something, how do you know whether it needs to be treated? Now, smoking was a little bit better, but again, I would certainly say I'd like to see that much better than 80%. It's such a critical key risk factor for so many things. And again, once it's recorded, you can see that it's recorded and you can see the red, you need to do something about it. Then next one down was a little bit surprising. Now we're talking, about people who are eligible. So we're talking about 45 years and over. So within the last 5 years, just over half had a lipid recorded. Now, if you look at the RACGP guidelines, we should actually be offering it to all of those people. So again, I would like to see that actually increased, and certainly so that we can have a discussion around what their risk is. Now, the last one looks absolutely dreadful, but we've got to realise that they took this out on a hemoglobin A1C. Now, we don't routinely do hemoglobin A1Cs on people 45 years and over. So, I hope most of us are actually using the OSD risk. And so that's why that aspect is particularly low. But certainly if they're high risk, we would expect people to be doing it. But if you then look at it, only about 17% are actually having all the things done to be able to calculate an absolute cardiovascular risk. Now, we saw that initial slide. We see the impact that heart disease has on our population. And a lot of these we can actually prevent if we measure, if we capture them early enough. So the message here is, the heart health check is certainly a great way of focusing our attention on heart disease.
Very good, thank you. Thank you, Ralph. So there seems to be an underuse of the CVD risk calculators, and a lot of primary care clinicians must already be assessing these risk factors on a regular basis. And are we really doing that poorly in this area?
Yeah, look, I think I've jumped ahead a little bit.
You've probably answered a lot of that with the data.
I think the acceptance of the absolute cardiovascular risk calculator as a fundamental part of the way we do business has still got a long way to go. And so this is why I think having a focus on cardiovascular or absolute cardiovascular risk in a situation when you can systematise it within our practice using these new ITA numbers, it's about time. It took their Heart Foundation a long time to get this number through, but they got it there. So I'm sure this number will now go up. And, already I think there's been about 75,000 claims done.
Yes.
So it's been a huge
in the
increase.
first 9 months.
Yes.
That's right.
So it's really good to see.
And I think that also when the MBS item number was released, a lot of GPs would be saying, well, we're already doing this, we're already doing it. But in actual fact, the data perhaps shows otherwise, that there's not a structured approach to care. So they may be doing it, but as you said, we can't capture that to see what they're doing.
Look, I've had a long relationship with the collaboratives, and my view has always been, if you can't show me, if you can't pull out the figures and demonstrate to me that you're doing well, it's not being done. Because at the end of the day, if it's not captured and you can't show, well, it's not going to remind you that you need to have it done. So yes, GPs may be doing it, but they need to record it in the appropriate place so that we can then capture that data and then we can actually work with it. Yeah, I can see you nodding about that one. So
I am.
It's really about that structured approach to care and, as you said, capturing the data in the appropriate place so that then the data can be pulled out. There's no point if it's in free text boxes where it can't be recorded. So blood pressures need to be in the software.
blood pressure box, yes.
Yes, blood pressures in the blood pressure box. It's a simple analogy, isn't it? But just not always achieved, and so therefore you're not collecting the data that you're needing. I'm just going to check because there is actually a question that's come through. So thank you, Jessica from New South Wales. Jessica asks, how do we factor in the additional information that we collect, like ethnicity, physical activity, or family history?
I mean, look, it's a great question, and you know, in one way they've kept the calculator nice and simple so it can be applied to in a very quick manner and a broad way. But look, at the end of the day, we are clinicians, and you know, we always make clinical judgments. The absolute cardiovascular risk is a guide. It's never an absolute. So, you know, if you've got someone who may score something like 9, 10%, but they come out as being very, very high risk, or you know, but you know that they've got a family history of, you know, parents, a father dying at 45 of heart disease. Yeah, you're going to automatically increase that risk to a certain degree. So, you know, please, it is a guideline. It's not an absolute, you know, in terms of what we do as clinicians. Still use your clinical acumen. You know, certainly if you're talking about, you know, people from certain ethnic groups, again, you need to be aware there are certain groups that are at high risk. And, you know, you need to up-titrate, you know, that risk appropriately.
So I think that's important in what you're saying, and Lisa, in the nursing sector as well.
Yeah.
You as clinicians know your patients, so you know those other intricacies about the patient that can actually help form your clinical judgment.
And particularly, I think, like Ralph was saying, you know, we do, like it does come down to clinical judgment, and because as nurses we do spend quite a bit of time, you know, with the patients.
Yes.
You know, you get to know quite a bit about, you know, what they eat, where they go for exercise, if they don't exercise, whether they smoke or not, you know, plus obviously their ethnicity.
It probably leads me into the next question about, let's sort of unpack and explore the heart health check. So Lisa, we know that you do them within your practice. Yep. Would you be able to tell us a bit more about how your practice actually provides the heart health check to through the clinic, and how are the nurses involved and what is their role?
Yeah, so there are two ways, I suppose you could say, that we look at doing the healthy heart assessment. So we either use our data, so we use, in our particular place, it's PenCat. So, you know, I'll do some collecting from PenCat to see which patients are at risk of cardiovascular disease. And we basically also look at patients that are above 45 that come into the clinic. And using, you know, obviously people's ages, it's, a great tool to implement.
And so I think with, unlike the preventative health assessments, like item 699 can be claimed annually and covers all the ranges. And I think that's an area where people have some concern about, well, why would I do the heart health item number when the remuneration for that is lesser than a standard item number or so? And that response there is that we're capturing a group of people also that don't fit into the box of the 45 to 49 health assessment, or the 75 plus, or alternate for the Aboriginal and Torres Strait Islander populations for their age groups. So you are actually, there's a group of people that can have a structured, systemised check that fits in with the Medicare item numbers.
Yeah,
Absolutely.
Yeah.
Because,
Kathy?
we used to do we still do a 45 to 49 health check, and then I'd say to patients, well, this is your opportunity for the one-off health check, because the next health check that was scheduled is when you're 75, and a lot is going to happen between now and then, the impact of your family history, risky lifestyle behaviours, maybe some chronic conditions that you already have that will impact on more. And I'm really excited that this is now an opportunity for us to be a lot more proactive in general practice, and every year do a quick health check. It's not going to be something that needs to take an hour. It's something that once you've got your systems going can be very quick and succinct and be worked in with normal general practice and seeing patients and the sorts of things we do, be it a regular review or a review of care plans, health checks. Instead.
And for us, it has become pretty much just a normal everyday experience for our patients. So we initially started the process with APNA through a grant a couple of years ago, where we looked at cardiovascular at risk clinic. And through that process, we were able to really target our patients. And I think we're 3 years now post the project, struggling with words, the project, and it's just become embedded into everyday practice. So patients will come to see me, and I'll go through the healthy heart assessment with them. I'll give them education, and we have the GP then that will do some, follow up and input as well.
And did it take long for the patients to be on board with that? Because that's a bit of a shift in change. And I remember when health assessments first came in, the patients were often asking, what does this mean? What is all this? And then annually having their 75 plus health assessments, they would ring up and say, I'm due for my assessment, and they'd actually know it. So how has that shift in culture for the patient?
I think it's been really good because once you give them an actual cardiovascular risk score and you actually say to them, well, this is where you're situated, sometimes patients are quite shocked. And like you said earlier, where you were talking about the fact that some patients may not necessarily have all of those risk factors, such as the cholesterol, the smoking, the diabetes, family history of CVD. It could sometimes be that we know their habits, we know their culture, and we know that when they say to us, "Oh no, I haven't had, that chocolate or that McDonald's," we actually know that yes, that is something that they do quite regularly. So I think building that relationship too as a practice nurse is quite vital in doing the healthy heart, and giving them the resources as well. Providing them then with resources, follow up whether they need to come back, and touch base again in a month's time to see where they're at, giving them advice on exercise.
If you're having those conversations with them, they're more a part of their own care, aren't they?
Exactly.
So they're more likely to say, yes, I want to come back and have this followed up further, have further discussion, work through goals.
That's right. That's right.
You know what I like about this?
Yes.
I can hear the nurses talking about organising my practice, organising the patients to come in, and really getting this in a routine way. It just sounds fantastic. So,
thank you, Ralph. You're awesome.
You can't stop. You can't stop nurses talking, can you?
Not at all.
Lisa, I'd also perhaps now like you to run through this flowchart that's appearing on the screen.
Sure.
Please.
Yep. So initially what we do is we would do a search. So like I said before, we'd use some sort of data tool, whether it be Polar or PenCat, or people I know also use Medical Director or Best Practice. And we'd recall patients. We start identifying which patients are eligible to come in. The other thing that we do in our clinic is quite opportunistic. So a lot of the time the patient will present for a visit with the GP. If I can catch them before they see the GP,
Yes.
I'm often doing just a blood pressure, height, weight, waist, and then possibly an ECG. And we look and see whether the person is eligible or not. And if they're eligible, then, we do a 699. We look at, like I said, we look at the risk factors, so the BMI, the BP, and like Ralph said, it is integral that this information gets put in the right space into the software.
We really can't stress that enough, can
No,
we?
not at all.
Probably all say that throughout the course of this evening.
That's right. Because again, without the data being in the right place, we're not going to be able to identify those patients. And then from there, the GP tidies up, finishes off, completes the risk assessment, and recommendations or interventions put in place. And again, I think it's really important that we look at this as a team approach so that it is the GP, it is the practice nurse that are coming together with the patient, where we're looking at combining that collaboration and coming up with the recommendations and interventions, because not all patients are going to be able to run a marathon. Not all patients will be able to eat, their third of veggie, of meat, and their, depend.
Portion
That's
control,
right. Exactly. And then obviously, as practice nurses, we provide lifestyle activities. We assist with giving out information. I often give out information from the Heart Foundation to the patients as a resource. And then we assist with the management plan. And then after that, the patient is normally recalled within 12 months, so that we can monitor and see if there's been improvement, or if there hasn't, then we reassess. And then, again, following up and monitoring of their risk factors, really important. So again, doing another cardiovascular risk assessment, medication, whether that's accurate or not, or needs adjusting, really important to do.
So it's really, it really shows that value of a team approach to care. And I think, Kathy, I'm going to direct to you in a moment as well. But in my mind, it's actually a whole team approach, and that's also the non-clinical staff, the reception staff that are the meet and greet and the front of the clinic. When patients are coming in and you're having a conversation here for a heart health check, that the non-clinical staff can have a bit of a response about what that is, and they sort of have a level of knowledge and understanding to their scope of what that is, and the nurse will see you and the GP will see you and having that conversation. So it really sort of shows that value of a team approach to care, which is probably then a good segue for me to speak to Kathy and ask about it sounds like how the item number is best implemented at a practice level to better maximise and improve patient outcomes. So how would you implement heart health checks at a practice level?
Yeah, so everyone can see on the screen right now, there's an example of Practice X, and so I'm not going to, it's not a quick answer to this, but our practice is privately billing, so it can occur with private billing. You might think that you have to bulk bill 699, and that is not necessarily the case. It can be tied in with normal practice billing. Generally, we'd allocate 30 minutes to the nurse and 30 minutes with the GP for the heart health check. Our practices are predominantly private billing, and working class families, a lot of professionals working in the city, and also students, and that includes postgraduate students as well, diverse ethnicity, and few Aboriginal patients, not an awful lot. But we open 6 days a week. We accommodate extended hours, so heart checks can be done later in the afternoon or on a Saturday morning as well with the GPs. And the GP, it's a mixed way where the GP actually identifies the patient that's at risk. So maybe they've got them to go and have a blood test and they've now got their results back. Maybe their cholesterol's high, and then that leads them into a discussion and having a quick heart health check. So it can be that quick that the GP might do it themselves. but often they'll involve the nurse, and as nurses we're very keen to have a look and constantly checking those records. Have they had a blood pressure recorded in the last 2 years? What's the smoking status like? Have they had lipids done in the last 5 years? And a HbA1c or a diabetes check in the last couple of years. So thinking about that all the time. And whilst we exclude patients for the heart health check that have cardiovascular disease, cardiovascular disease is not hypertension and it's not dyslipidemia, okay? So it's very important to know that you can still do heart health checks on those patients, because if I had a population of 5,000 patients that were eligible, and statistically 20% of those that are eligible for the cardiovascular risk check will have a high cardiovascular risk. So that's 1,000 patients, and of that 1,000, we know statistically that none of those, 70% of those, have got hypertension and dyslipidemia that would need treatment per the Heart Foundation clinical guidelines. So if you don't want to have a major cardiac event in your practice or in your practice population, it's time to get to it. And I think the QI-PIP incentive is certainly a very good incentive to get us into doing that, and I'll talk a little bit more about that in a sec. But just looking at this Practice X, so it can be with the GP, but also as nurses we often can identify patients. Maybe we've finished doing a 45 to 49 health check and we can reset a reminder for 12 months' time. And it's not like the diabetes risk check, they have to come up with a high diabetes risk to do the billing. This, you can always do the billing, okay, just once every 12 months, 699. So, and maybe it's when you're taking the bloods, you go, oh, okay, you're seeing that you're taking bloods for lipids and maybe a fasting BSL, and you can say, oh, have you had a heart health check? Or it could be, we're about to hit it all, is the flu season, and we know,
a good time to see
right? That's a really
patients.
good time, because we know that those that have got a higher risk of some medical conditions, and not necessarily heart disease, will be coming into our practices for a flu shot, as well as those really high-stressed, busy professionals that work in the city that could smoke, high risky lifestyle behaviours. They're really good because they actually don't want to spend a lot of time off work getting sick, so it's like quick, and it can be a quick way of checking those sorts of people. So think about it when you're taking blood, when a flu shot. The other thing that our risky population is people with mental health conditions. So we know through research that these people have a higher risk of cardiovascular disease. And so think about it, when they come in for a care plan review, mental health care plan review, or a mental health care plan, you see them on the doctor's list and they're waiting, the doctor's running, well, often half an hour late. And the patients don't mind waiting half an hour for the doctor, but it's certainly a great time for the nurses to think about a cardiovascular risk assessment, because you can bill a mental health care plan in with a cardiovascular 699.
It's probably just a good time to interrupt there, Kathy, and ask you. We do have a question coming through from Katie from Victoria asks, and there's quite actually a number of questions the same. Can we claim a chronic disease management plan with the 699 item?
You most certainly can.
Did everyone hear that? You most certainly can.
Yeah, only when the patient has cardiovascular disease, so they've had a stroke, had maybe an AMI, a non-STEMI, then you cannot. Okay, that's cardiovascular disease. But think all the time they could have chronic kidney disease, and they're at a really high risk of cardiovascular, having a heart attack.
Diabetes, I think.
Seriously, and diabetes. So might not necessarily come up as having cardiovascular disease with diabetes, but we know they're the target patients. They're a really good lot to capture.
And so, certainly incorporating that 699 to some of those health plan or GP management plans that you're doing specifically around people at high risk. So we talked about mental health. We do GP management plans for people with mental health around diet and exercise because we think that's important. But doing a 699 with it actually focus you on their risk of heart disease.
Yeah.
You know, people with rheumatoid arthritis, you know, they're a higher risk group. So you could use this as a way of formalising, you know, that heart health check for a whole range of people with chronic conditions.
That's right. That's right. It really works very well when we are looking at chronic conditions, you know, to really implement this healthy heart check.
Yeah.
Because it's not.
Yeah.
And so to recap then on that response is yes, that you can claim at 699.
Answer the question,
I know.
yes.
Well, I'm just making sure because it's coming up. There's lots of questions on a similar vein, so I just want to make
don't
sure
forget,
that.
like every year you do a care plan, you do a 699 with it.
And so long
Right,
as
new
they
care
meet-
plan, new 699.
So long as they meet the requirements for the chronic disease management plan, of course, and the eligibility for the heart health check. And I also think if you're uncertain about that, the MBS guidelines is the actual Bible, if you like, that we have to work towards. So it's not our opinions. It's, you know, the MBS. So if people are uncertain about what can be claimed, they really need to get onto MBS online and have a look at the actual item descriptor to make sure that you're meeting the actual MBS criteria for claiming.
Yeah. And the other thing is when you do a heart health check, obviously you set a reminder in the system for another 12 months' time, okay? So that's really important to keep it going through your whole team. Now, the other way that was on that Practice X slide that we had just had previously was also, and Lisa's alluded to it, is the data mining that can go on. Now, we could use our clinical programs for that. We could use PenCat or we could use Polar. So Polar is through some other primary health networks, some have PenCat, and other people choose to use their clinical software. So I've just, up on the slide there is an example of the PenCat 4, and you'll see across the top there that the patients have been selected from 45 to 74 years of age, and they're active patients, okay? So that brought something that we're a very old practice, been around for many, many years. So our actual database is like over 60,000 patients, and but the active patients in that age group have come in there on that. And then on the next, then we would select cardiovascular risk instead of that on the circle, and then do a recalculation. You always hit recalculate with PenCat, and I'm pretty sure you probably do with Polar. And then you can get your, like the icing on the cake is the very top, bright red is the red alert. Very, very high risk of a cardiovascular event in the next 5 years. And so if you were looking at this and you've got, who am I going to target? Who would you target? Would you target the ones 45 to 49 that you've probably had a good go at on a health check recently? Or would you start looking at your over 50s for making a big impact? Now, those that are in the yellow there, they're likely to have hypertension, dyslipidemia, maybe mental health conditions that are going to put them at higher risk of heart disease. They might have diabetes as well, or chronic kidney disease, okay? Now, they're guaranteed care plans, basically. So if you did a heart health check on that, you would identify, and you'd have to code all that. Remember, we're going to be coding because we're going to be keep coming back and measuring these things. They would be a great way to start a nurse clinic, all right? So if you wanted to look for that, and by doing that, you'd select on that, and then the next slide, it'll give you the actual names. So I know on this it's the de-identified data, but certainly you would be able to pull out, extract the list of the patients that you would want to call in from that. It's a pretty clever program. But then we think about, what are the gaps? Who's missing? Who's incomplete? Now, we remember from Rolf's slide earlier, only 17% have actually got all 4 key items to be able to actually calculate a cardiovascular risk. So what we would do then is go to this slide and find the incomplete ones, okay? And then we could do an extraction. Now, I might have lost a lot of you, and that's okay because we're all learning and we're all on this new QI-PIP road as well. And so we're all learning these sorts of tools, but there's PenCat recipes that you can refer to, okay? And also their team is fabulous support. All your primary health networks offer fabulous support for this, okay?
To say that, Kathy, that, you know, nurses can tap into their PHN and seek support and have staff come out to the practice and help them through this data collection process if they're uncertain.
And they're a fabulous support because they're with you through the thick and thin, through general practices. You get your ups and downs, but this way you can measure how you're going, and it's always nice to actually see where you're at, where you've actually improved your numbers. So this incomplete list would then give you a list of the patients that haven't over 50 haven't had or over 45 haven't had a lipids check at all in the last 5 years. All right, so they're important to capture too. So, and maybe you're going to be looking at sending out invites using your whole practice team. Maybe you're going to get your receptionist to give them the list and they can chip away at sending out some invites. Might be that. You've just got to work out how many resources you've got. Not everyone's got people coming out of their ears, and most people don't. We're all pretty time poor. So just having a little bit of a process, who's doing what, who's doing the reminders is very important too.
I think too you can implement Topbar. So for people that have PenCat in their clinics, Topbar sits at the top of your software and it is a really good tool to use that also identifies the missing, whether it's a blood pressure or whether it's
a good prompting
that's
tool,
right,
isn't it?
exactly.
Yeah.
And again, you know, to clean up your data and put it in the right place, so that when you are looking again at your cardiovascular at-risk patients, you know, using that Topbar is really helpful.
We're getting back to that point again of clean data
right.
and data in the right spot.
Yeah, that's right. So if you can't see that they've had a blood pressure recorded in the last couple of years, maybe it's just that someone free texted it in and it's just a matter of looking through the notes and putting it in for that date. Okay, so
And so again, for us, I suppose at the clinic where I am, you know, majority of people will see the nurse during the time that they're at the clinic, and we, you know, it's almost every time that we're doing a blood pressure, a height, a weight, a waist check, you know, for the patient.
You're just building that into
That's
your
right.
everyday routine.
That's right, and updating the software. So at the moment, I'm noticing a lot of updates are coming for smoking and alcohol. So obviously, you know, we've hit the, I think it's 5-year mark, and the software's prompting me to redo that. So I think again, really using those tools when we are prompted as nurses, again, when we've got the patient history open, to clean up and you know, see that yes, we do have a patient that is at risk. Let's get the 699 happening.
Yeah.
I've got another question come through here from Linda in Victoria asking, can you clarify if the nurse time is factored into the time of the professional attendance by the GP of at least 20 minutes, which is the billing guidelines?
Yeah, that's a fabulous question,
Kathy?
and that's what a lot of people are asking, aren't they? Because certainly it is the quick answer. The Heart Foundation have discussed it with the MBS, and it's definitely counted as part of the thing, like your 75 health assessment.
Health
Everything,
assessments.
assessments.
So
That's right.
yeah, it's
So it
exactly
is
the same.
definitely, yeah.
So it's
So that was a
along the
great
same
question, Linda.
the same line of if it's the same requirements as the health assessment.
Yep.
So if how the nurse's time is factored in, so it's similar to that. So good, thank you. We've answered that question. And while we're there, I do have another question from Ben, who does ask, and I'm not quite sure who's going to answer this question, but how have you encouraged GPs to put the data in the right fields and reduce free text?
Okay,
Who'd like to answer
Called
that?
accreditation, isn't it?
Yes.
I won't listen. No, that's right.
So
Go for it, Lise.
I know that there are a few clinics that have actually started putting up in their staff
Coffee,
kitchens,
yes,
coughing
that's right.
areas, you know, regularly which GPs are making improvements in what areas and where the data, So it has really, I suppose, incentivised the GPs when they start to see their name against somebody else's name and, so again, trying to, that's right. Yeah. So I know that that's been really, really helpful for some clinics out there.
But, look, let me say, I'm nice and lazy. And isn't this why I have nurses? They can then do the annual health check, do all that beautifully.
No, you don't have nurses. Nurses work collaboratively with you in your practice, I am sure.
But look, it is a tough one, and it's, getting people used to actually opening up that recording section and actually putting in the data in the right spot. Once you do it on a regular basis, it's actually easy, but it's just getting them started.
And I think Kathy made a comment before about, it's called accreditation, which is a good, well, really it's a good thing to do, and it's the right thing to do for the patient care. Yeah. The word accreditation just helps us get along and do it.
Yeah, particularly the smoking status, right, everyone?
That's right.
And I also think, remembering that comment that accreditation is everybody's business. Not just down to one or two in the practice. Yeah. Everybody has a role to play. Yeah. So if you employ that team approach to care and to processes within your practice, everybody's working on it together, and that can help with.
Yeah, and I'm just thinking too while you're talking with the data. You'll get a patient discharged from hospital and they send it to you in paper what their blood results were. If you rang that lab and got it to be sent in as anodised little
HL7,
HL7 format, which is where the data gets extracted, you won't have to. You'll know then on your extraction. Yeah. Whereas if it just sat in the medical records in the ether, it won't actually get extracted. So just follow them up and ask them to send it electronically. It'll make your life a lot easier.
There are, I know, particular areas. So I know with diabetes, for example, if a HbA1c is missing in that instance, we can actually go into the diabetes record and put the HbA1c in. So again...
In certain programs.
Yeah.
In certain limited ones.
Okay, in certain medical softwares. Yeah, the other thing I just wanted to mention too was... for Ben, was the QI PIP. So again, we're looking at data here, we're looking at making improvements, maybe focusing for a month on let's clean up the, particular data. So using, some of this QI PIP incentive that's coming out will hopefully as well entice and build better practices, perhaps we could say, for GPs and, for nurses to try and make, again, put the data in the right place.
Pull up an Excel spreadsheet, put it all in for the month, take it to your GP meetings month by month, they'll see how they're improving.
I know there is a GP in Victoria in the northwest region that actually spent, I can't remember if it was 6 months in his clinic where he actually cleaned up all of his data and with big job, massive job. But he's dedicated to the cause and he really wanted to have the best outcomes for his patients. And again, he was able to do things like the healthy heart assessment because he took that time. So maybe we do have to go back a little bit to go forward.
And look, I think you mentioned one word that we really haven't talked about, and that was outcome. So one great thing is, yes, to do the heart health assessment and actually work out what the risk is. But if you've got someone who's at high risk, you've then got to start making sure that they're treated to target. So certainly there was some data from England when they've been doing heart health assessments for a bit longer, where in fact blood pressure actually improved, quality of life improved. I mean, they don't have mortality data because it's a little bit harder to capture. But using something like the heart health check can certainly focus the practice on actually getting things right, which we know if they're at high risk, they all go on a statin, they all go on an ACE inhibitor or an ARB. You do those two things. Of course, if they're a smoker, you stop their smoking. You'll have a huge impact in outcomes. So, tackling the therapeutic inertia as a nurse, highlight the fact, high risk, they need to be on a statin and an ACE inhibitor, even if they're normotensive. So, and that's a really important issue to get across.
Yeah.
I know there's pathology companies out there too that will actually come and do some work with you around the data, and they sometimes do come out to the clinic and they'll say, okay, well, let's see who is on a particular medication or where you might have missed, according to their pathology results. So whether it be their cardiovascular
Really,
pathology.
it's about having team approach, team conversations. So Kathy mentioned before, at your monthly practice meeting, a lot of practices may not even have meetings, so that might even be the first thing. Have regular meetings
and
with...
it's a standing item, yeah.
Yes, as a
QI,
standing
PIP,
item.
Cardiovascular risk.
And so something like perhaps, in-house competition within the clinic, awards and prizes if that's what it takes, noting, but actually having everybody working towards that and just working probably on finding the right strategy for your practice.
And sharing the win then, I think, is really important too. I think it's great that we can do these things, but I think, again, as a clinic, if you're, at the end of the month, you bring it up at your meeting and say, yeah, well, look, this is what we've achieved. We've got this many blood pressures recorded
It's a win for all and ultimately a win for the patient.
That's right.
So I've got a couple of other...
Yeah, but you can actually work that out. So again, I'm always on about outcomes. So if you're actually assessing people, and we had 1,000 people at high risk, and we said about 800 or so weren't on appropriate treatments, that if you put them on that treatment, you can actually redo their risk calculator. You can work out how many heart attacks you could have prevented. And maybe that's something that you can present to your GPs, because that actually hits home because it's about their patients.
I've got a couple of other questions that I'd like to ask of the team. Jane asks, if the patient is high risk, what is the best way to record in past medical history or just in the progress notes?
Where do you record it? So certainly when you do the risk assessment, it will come up as a high on the database. Yes, actually, what did you do?
What did we do? That's really hard for me to remember, but I think we actually put it in the past history. I think that's where we recorded it.
Because we certainly used to, for chronic kidney disease, we code stage 1, stage 2, stage 3, stage 4. And that may be something that we need to consider taking to the software vendors and having that coded in.
To make it easy.
So
there's a great question, Jane, from South Australia, who's potentially stumped the panel, but we'll take that on board as well, and the Heart Foundation can explore that further and hopefully make that a bit better.
Fantastic.
Another, a different Jane this time asks, do you wait until you have the patient back with their bloods before you can bill a 699?
We do. We do.
You need the
recent.
Because you have to calculate the actual risk, and you can't calculate the risk unless you have all the results.
Right.
So yes.
And I think it gives a good example back on one of the slides that we had earlier up, where it showed where you actually enter the cardiovascular risk score. So it shows you there where you've got to have I think it's the LDL and...
HDL and total cholesterol.
That's right, HDL and total cholesterol, entered, and the blood pressure.
Or diabetes risk.
Yeah.
Very good. And another one from Emily. Would you add an ECG onto the heart health check?
So again, in my practice, we do we do that. So it's standard that everybody that has a healthy heart assessment done has an ECG.
Like a baseline ECG.
Yeah, baseline ECG. And then again, because we've done this for a couple of years, we are recalling the patient and they are having an ECG. And for us, we've actually gone that one step further where we have them have an ABI. We've got an ABI machine now. And we incorporate that as well into our healthy heart assessment.
Okay, so do practices have to purchase an ABI?
No, they don't need to purchase it. It's just, again, I think because we've,
you're quite established with
that's
the
right.
process.
So we're just we're moving a bit more forward.
And I could imagine that not all practices...
Some practices, it's more of a clinical decision
based
on the risk at the time and the symptoms the patient might have been having as well.
Yeah, and I guess capacity as well. If for doing an ECG for every heart health check, that really boils down to capacity at the practice.
That's right.
So can I be a little bit controversial then?
Please do.
Sure.
So, again, when you have someone who you've done an absolute cardiovascular risk on, and it comes up moderate, but you're thinking, I'm not so sure, Have any of you actually used the coronary calcium score, you know, the CT calcium? Because I've actually started to do that a little bit more for that moderate risk group. And, you know, sometimes you get a shock.
That's right.
You know, that they're really heavily calcified and you think, oh my gosh.
Yeah.
And then occasionally you'll have someone with a 0 and you can say, oh, well, for you, I'm not so worried.
Yeah.
So I'm starting to include that calcium score as part of it on selected patients, so not as a general thing, but certainly on some of those moderate ones where I'm not quite sure whether it really reflects the risk.
Yeah, so
Maybe in stress ECG too, you might
Yeah,
consider
not unless they have
that?
symptoms.
Not as much.
So yeah, but I think the calcium score, I do like that.
and I've heard, I've heard again from other clinics out there that yes, this is coming into a new vogue, perhaps, I don't know.
Well,
but,
the Heart
you know,
Foundation is going to come out with a position statement on this over the next 6 months, because I think it's going to be very important for practitioners.
Yeah,
Mm.
yeah.
And I think it's important for people that are listening that are perhaps starting out in this and maybe feeling a bit overwhelmed or not, is taking, you know, small bites of the elephant. So just start somewhere, just start small, just start. And you're actually then chipping away and doing bits. So don't try to
eat the whole elephant all at once.
try to eat the whole elephant all at once, because that then leads to fatigue.
That's right. And it might just be that you have that patient that you're collecting the blood on, or, you know, you identify might have ethnicity that is at greater risk. And again, you might just want to give it a, you know, give it a go and see how it works out.
One thing I would say to the practices, you know, 12 months between risk assessments, is actually quite a long time. And so, you know, if you've identified someone at high risk and you're doing an intervention, you really need to see them much earlier to see the impact of that intervention. You can't claim the heart health check again for 12 months, but don't wait the 12 months before you review the risk factors, because you need to get that momentum with the patient.
So it could be someone with hypertension that you've started an antihypertensive.
See them again in a month and check to make sure.
And put them in on care plan.
Yep.
Yep.
Can review them.
And that's
with
what
your
we do.
pathology. So
The
maybe-
GP will review it, and normally on the healthy heart assessment, he or she will put down, you know, one month, 6 months, 12 months, so that again it's getting captured on the hard copy, but also getting entered into the recall system.
Back to your structured approach.
Yeah.
Yeah, and the elephant in the cupboard is always that there's a really good NPS statistic of who actually fills out their scripts, right? So it's not great. So it's a hard thing because they can't feel blood pressure, they can't feel dyslipidemia. It's not something you feel, and it's only when the wheels fall off that there's a major problem.
And
Then they're ready. You know, in the coronary care unit, then they're ready to take.
And so certainly the other thing then, I mean, exactly that point, getting people to understand what their risk really means. And so to have charts or, you know, those little human figures that actually comes up, or using coloured diagrams, and make sure that they understand that if they've got an absolute risk of 20%, as you were saying before, that's 1 in 5 are going to have an event or die in the next 5 years. That's 1 in 5.
May not come home from work that day.
Yep.
May end up in coronary care or even worse.
So a lot of it's how we actually tell or get that risk understood.
Get the message across.
And I actually print off the results. So the printing's very powerful. So people learn all sorts of different ways, and they can sit there going, I've got to get back to work, Then you give them that and they're like, oh, should I take that home? I think, I don't know whether I should take that home.
Put it
Well,
on the
I'm going to
fridge
be
and
very
look at
happy
it every
about that.
day.
It's powerful.
when you open the food.
I've got another question from Michelle, who says, we currently promote the heart health check when talking about risk factors for CVD at our cardiac rehab sessions for friends and family members of the patients who attend. Is there anything more you would suggest to encourage people to take this opportunity up with their GP? That's a good question.
That is a good question.
So promoting the heart health check to family and friends of patients that obviously have had cardiac.
You know, the number of patients or people that will come in who've had a friend, you know, 45, 48, who've actually had a heart attack, who will then come in for a heart health check, you know. So there is that flow-on effect, and certainly using the material on the National Heart website to actually give patients, I think, is a really good way of doing it. So having the information, handing it to patients,
Yep.
and saying it's now available for a focused assessment of their heart risk.
Otherwise, just encouraging them to ring their general practice and have a chat to the nurse and ask them how to go about it. Then that you sort of got their name, got them to follow up.
And I
Is,
think
a really powerful
I think
thing.
too, like Ralph said, really giving that hard copy across. Having those resources there, saying, well, this is really important. Have a read, go and see your GP.
And I'm just going to ask the final question for our session. Lynn from South Australia asked, what lifestyle interventions would you recommend during the heart health check?
Well,
SNAP. SNAP, I agree with that one.
Yeah. And again,
So would you just explain SNAP for anyone who may not know what that means?
There's a smoking, nutrition, alcohol and physical activity.
Yeah,
So, these are the fundamental things that we do regularly, but it's really about actually engaging with the patient on how to do this. And so this is where I'm saying, 12 months between visits, it's too long to actually put the behaviours into place. And so, we've taught our nurses around motivational interviewing. We get the patients to come back. We actually ask them how they're going. Did you actually get to the exercise physiologist? And so it moves on. But you've got to close that loop. You've got to get them coming back. You've got to try and capture them.
Yep, I would agree with what you're saying. And obviously, every patient is different, depending what other comorbidities they may have. So working again within the limitation of that patient, and it might just be that they start off doing, 10 minutes, and you're, something.
Yes.
Just something. Or you might give them some exercises to do in the chair because they're not that mobile. So, or cutting their portion down just to, a tiny bit. It doesn't have to be everything at once, like you said earlier too, Mark.
Chunking it down is very important. Working out what motivates them. Sometimes it's mental health, that they're in a really bad place and they need some counselling there. And other times it's they're eating meat pies, they can't cook, they don't have time, and working out strategies with them on how to eat a healthier diet as well.
And there are lots of resources out in the community. I'm sure people are aware of them. I mean, my nurse has a huge list. And I'm not quite sure how she manages to choose who goes where because it seems to vary a bit. So I'm sure there's a lot of matching going on.
What do they really need? Want a lot of support, or they just want to be set up on a program? Yeah, that's right, exactly. And I get worried with the new wave of all these pseudo meat burgers and things like that that are actually loaded in fat and loaded in sugar and salt. And where is that going to put our population? So if you do have someone, for goodness sakes, that's decided to be vegan, just ask them what do they eat. So what are they eating, and you'll be surprised. So there's a lot more
We're just about
information
at a point where we're going to wrap up. So just very briefly, I'd just like to ask each of you, what would be one thing that the practice can do to get more patients to have a heart health check?
See, I would tackle it from more the other way. I would actually be using the practice to use a heart health check to make sure that we're managing risk factors appropriately. Get rid of that therapeutic inertia, get people on the right treatment, make sure that we're going to prevent that first heart attack.
Very good.
Yeah.
Kathy?
I think, definitely setting up the easiest thing if you're already doing 45 to 49 health checks, already doing care plans, is setting a reminder in for every year. That's easy sort of stuff.
And I would suggest even putting up, a little display for a month in your waiting room where you're actually saying, this month we are targeting healthy hearts. Yep. Are you interested?
February, perfect time.
Valentine's
Day. Get
That's
on
right.
board. You can start something very soon. I think also it boils down once again to that team approach.
Yep.
That team approach to care. Get everybody within the practice team on board to their level and scope. So that then the patients are having their questions answered appropriately and then they feel a part of it as well.
Chatting at meetings, what are the barriers, what are the facilitators, what things are going to work, what isn't going to work. Yep. Your practice.
Well, thanks very much, Ralph and Lisa and Kathy, for joining me tonight for the webinar. I hope that we've been able to answer the questions that have been coming through, and I hope that you sitting at home watching had questions. I hope we answered them as we went along. I just do want to let you know that if you want more information or access to the resources, please visit the Heart Foundation website, which is heartfoundation.org.au.
I've been waiting to do that all day.
I'll just say it again, heartfoundation.org.au on the website or the resources tab of this webinar browser. I'd like to thank Ralph, Lisa and Kathy once again for joining me and providing your clinical context. Everyone, please be advised that an evaluation form will follow after this webinar. So we really do appreciate it if you could complete the evaluation form. It helps us to know what kinds of, if we're on the right track in providing the information to you that you need, and will help the Heart Foundation and APNA know for future which direction to deliver certain education. So please complete the evaluation form. And also to make you aware that this webinar has been recorded and will be made available on the National Heart Foundation website in due course. And those that have registered for this will get notification of the recording of the webinar. So once again, I'd just like to thank you all for joining us, and thank you for joining us tonight. Good night.